So how do we treat inhalation injury? Most of these patients are going to end up on mechanical ventilation. We definitely need to use some type of pharmacologic agent to aid in the patient's breathing and to help mobilize any ash or secretions that are within the airways. These patients are going to have a very long road of recovery, so an early tracheostomy should be considered. We will talk a little bit more in the program about when tracheostomies are performed or should be performed. But because this is going to be a long process, we don't usually wait as long as we would with other types of diseases. And of course, we want to use evidence-based medicine to optimize the patient outcomes. Not every inhalation injury is the same. It could be an inhalation injury from a chemical, which may be treated differently than if it was a burn inhalation injury. And keep in mind that your patient is going to go through some events that you need to be aware of so that you are able to clinically support them. Usually in acute upper airway obstruction, a lot of this is going to come from swelling and edema. Bronchospasm, again, this can be from the irritation from the smoke itself, or it could be caused by some of the chemicals that the patient has inhaled. When we talked about the various things that can combust, keep in mind that clothing is made mostly of synthetic materials. So those chemicals will be closer to the patient's face and can potentially cause bronchospasm from those chemicals. Small airway obstruction, this can definitely occur from either collapse of the small airways due to edema and bronchospasm, or it can occur from being occluded with excessive secretions or mix those secretions with ash, and it almost acts like concrete. Infection. Your patient is going to have infection not only from their airway, but also throughout the rest of their body, because they will have burns across their body if it is a thermal burn. So your patient is going to develop various types of infections. We want to keep things as clean as possible to try to diminish the transmission of any type of pathogen. And the final one is respiratory failure. Respiratory failure usually from hypoxia and hypoxemia, but it can also be from hypercarbia. So your patient will need support, and as we said, probably mechanical ventilation. Now, how do we manage these inhalation injuries? Well, as I said, airway obstruction is caused by mucosal edema that develops over time. Yes, your patient's going to have edema right off the bat from the smoke inhalation or the chemical inhalation, but it can still continue to develop even after the initial injury. Bronchospasm from the aerosolized irritants, usually 24 to 48 hours, and usually more prevalent in younger children than in adults. Do keep in mind that you could have an asthmatic adult that may be more sensitive, and you would see this in those types of patients as well. Aggressive secretion clearance techniques and adequate humidification. We want to keep those airways nice and wet so that the ash and the soot and the dead tissue that's sloughing off does not dry out, become hard, and unable to be moved into larger airways. So we may need to be suctioning them. We may need to be doing bronchoscopies on them to help keep the airways clear and to remove some of these thicker secretions that are mixed with ash and soot. Pulmonary infection develops in about 30 to 50% of all inhalation injuries. So respiratory failure is not uncommon. And as I said, these patients will or could go into ARDS. So any upper airway obstruction should be bypassed by endotracheal intubation or a tracheostomy. And we need to make sure that the endotracheal tube stays patent, meaning that it is clear of obstruction. We don't want the ash and the hardened secretions getting into the endotracheal tube and occluding the tube where we can then not ventilate our patient. And of course, bronchospasm should be treated with inhaled bronchodilators. We want to make sure we're giving adequate humidification to the patient. We don't want those secretions to desiccate. And pulmonary infection should be managed with the focus on the organisms identified by a sputum culture. So we don't just throw broad-spectrum antibiotics at these patients. We want to make sure that we are culturing that sputum and we are finding what exactly is growing and what type of antimicrobial do we need to treat that infection. As I said, children are going to be involved in burns, and you're going to see more intense bronchospasm from these aerosolized irritants in children because of their smaller airways. Carboxyhemoglobinemia. One of the byproducts of incomplete combustion is carbon monoxide. And you have learned that carbon monoxide has a 210 times greater affinity for hemoglobin than oxygen. So your patient, when they come into the emergency room and we see that they've been involved in some type of a fire, we've got that singed nose hair, we automatically assume they are going to have carboxyhemoglobinemia or carbon monoxide poisoning. So we are going to put them on 100% oxygen. Do not use pulse oximetry. We will talk about that later as to why it does not work. But remember, the MBRC is going to want you to put a pulse ox on that patient because they want to try to trip you up. Do not do that. These patients should be considered for hyperbaric oxygen, especially if they have any type of neurologic depression. And we always send a blood sample to the lab for them to run a carboxyhemoglobin with a co-oximeter. So your hospital doesn't have a hyperbaric chamber. Your patient comes in, you suspect that they have carbon monoxide poisoning. What therapy would you recommend? Well, you can only work with what you've got, so you put them on 100% oxygen. Another common thing that we see is hydrogen cyanide poisoning. This is produced by the combustion of nitrogen-containing compounds in a low oxygen atmosphere. It's more of a smoldering. And hydrogen cyanide binds to the cytochrome oxidase system, and it inhibits cellular metabolism. This results in tissue and systemic acidosis. The cells cannot utilize oxygen. So we want to make sure that we are cognizant of hydrogen cyanide poisoning, especially when you're talking about various synthetic materials that may have burned or didn't completely burn during the fire. So let's look at a couple of key points to wrap up. We want to make sure that we have adequate fluid resuscitation, especially in the first 24 hours after injury. About 20% of all burn patients that have burn injuries have some form of inhalation injury. And there are 5 predictable events that occur in a patient with inhalation injury: acute upper airway obstruction, bronchospasm, small airway obstruction, infection, and respiratory failure. Any clinician who cares for a burn patient should be prepared to deal with airway emergencies. And when we are ventilating these patients, we need to use lung protective ventilator strategy. We will talk more about that as we go through the program. Remember, carboxyhemoglobin is treated with 100% oxygen or a hyperbaric oxygen therapy, or both. If you have any questions about burns or inhalation injury, please make sure to put them in the discussion section of the D2L shell, and I will be happy to answer them.